a huge welcome to everybody for joining today. This is our inaugural free, fresh lunchtime webinar. Um, so we're absolutely delighted that we've had such great interest in coming along today and hear from the absolutely awesome Dr. Sharon Cox for this webinar, which is specifically going to look at tobacco addiction and nicotine dependence. And Sharon's going to really provide, huge amount of insight and her knowledge and expertise around that particular subject area, which I think is just incredibly timely for so many partners across the region, NHS and local authorities, in terms of, how we really do strive to help more and more smokers to quit smoking. For those of you who might not know me, I'm Ailsa Rutter. I'm the director of Fresh and Balance, which is the regional tobacco control programme. And I just thought it would be really helpful just to do 2 or 3 slides, just a quick little who we are, what we're up to, before I hand over the reins to Sharon, specifically for the topic today. And it was just to say that Joanna is our regional stop smoking systems manager. So she's going to be looking at the chat and she's going to be seeing the questions that are going to come up specifically for Sharon and when she does her presentation. And then we'll have a proper Q&A at the end. And if we run out of time and things, we will be pulling together the key questions, and we'll come up with an FAQ that we'll collaborate with Sharon upon. Just to let everybody know, this is being recorded because we wanted to be able to share this with colleagues who couldn't attend, and we'll put that on our K-Hub. But just move on to the next slide, if it will work. This is where it's so frustrating when technology doesn't work. Be patient, Ailsa. Give control. I might give it to Joanna, see if it works that way. See if you can flick to the next slide. Yay! Well done. Thank you. Welcome to the inaugural Friday lunchtime free webinar. It's going to be held on a quarterly basis, so everybody's welcome. Just a quick introduction to Fresh. We're a regional tobacco control programme. We've been running for nearly 20 years now, so we're the longest established UK regional tobacco control programme. We were launched in 2005. We're delighted to be funded by all 12 local authorities jointly with the North East and North Cumbria NHS Integrated Care Board. We're working at population level. We're working across a multi-strand, if you can just press that button, wonderful, a multi-strand comprehensive approach in terms of reducing smoking rates, providing and helping smokers to stop and stay stopped, protection from secondhand smoke, and reducing the uptake of smoking. And I just wanted to flag that these 8 key strands are very tried and tested. They're based on international experience. And it's just so helpful, I think, that the North East had this consistent approach, all of us together. And, we pull this together also for those of you involved in local tobacco alliances in terms of a local tobacco alliance plan every year. And all of these strands together are really important to help us drive down smoking rates. And it's just brilliant that through the collaboration in the region and through everybody working together, we have had the biggest drop in regional smoking of anywhere in England, and we have made wonderful progress, but we all absolutely know why there's still a lot more to be done, and smoking rates, as you'll hear from Sharon, are much higher in particular groups. The good news is, though, is the North East has got a very clear vision of the future we want. We are the only region that has this vision in terms of the declaration, and we know that, there is no magic solution to all of this. And really, more and more ever, we need to think of this from a health inequalities lens. All the policy measures and things in place, what impact are these going to have on health inequalities? And there is no room for complacency. Smoking rates will not continue to go down unless we continue to have effective action nationally, regionally, locally, and at community level. Just the next slide, please, Joanna. Thank you. And I think, some of you will be very familiar with this slide, and this is just the real reason why I'm passionate, the Fresh programme team are passionate, Sharon's passionate, is just, why we're here today is because way too many of our loved ones, John, if you can just press this slide, way too many of our loved ones have been lost to tobacco. And this is just a slide, and it's a slide that Ash, our wonderful team in Ash, like to keep updated. And it's just sad in a way, isn't it? But I bet everybody who's dialed in today would have a photograph of a loved one that they could have in this slide. And if we're just go to the next bit of it, and it just shows that 26% of all deaths in the last 50 years have been due to, you know, the tobacco industry peddling lethal combustible tobacco products. And that's my dad, top left with the tie on. Started at 11, died at 61 from COPD. Just horrendous. So it's a childhood addiction largely. And that's why, you know, we're so passionate that we've got this vision now. So 27th of September last year, the Northeast launched a very, very clear declaration for a smoke-free future. It was a wonderful conference of which Sharon spoke brilliantly. And it's very clear, really, what this declaration is. It's not controversial, really, in any sense, because how could anybody argue with wanting a smoke-free future free of the death and disease from tobacco? So that's when we launched it. That's Sir Liam Donaldson, the chair of our ICS, former CMO. It's Peter Kelly, the regional director for OHID, fantastic, passionate person who's been committed to tobacco control forever. And Amanda Healy, who's the really brilliant chair of the Association of Directors of Public Health Northeast. So it was just to say, if anybody wonders about what is the ultimate vision, this is what our vision is. And, you know, it's a smoke-free future, free of the death and disease from tobacco, you know, is needed. It's wanted and workable. This will improve, you know, the health and welfare of our most disadvantaged communities more than anything else. So I did just want to flag that to you, and it's on our website. And it's been brilliant recently. We've been to all 12 localities, and the FT and local authorities and other partners have come along and stood with a banner to show this collective commitment. Next slide. Thanks, Joe. Thank you. So I just wanted to also say, you know, that's people who sadly have our loved ones who have died, and why we need a smoke-free future. And I did just want to flag to everybody today the huge thanks that we have as a team to our smoking survivors, to the members of the public who increasingly are coming to us and saying they wanted to share their stories. So I did just want to flag to you all the most amazing, you know, fantastic campaign of smoking survivors. The latest phase launched this Monday. You know, we're on TV, we're on radio, we're on Facebook, we're on outdoor media. We've had an amazing response, and a huge thanks now for the left here is Sadie. Sadie lost her dad, Denham, who was the most lovely, beautiful, genuine, lovely man who'd been supporting us for a number of years, actually. She lost her dad to COPD, and Sadie's mum, Debbie, so Sadie and Debbie feature in our new TV ad. They're telling their story about how awful it is to, you know, to witness somebody you love slowly really suffocating from COPD, and, you know, the huge regrets Denham had, but how passionately he wanted them to continue his legacy. So a huge thanks. If you have seen that TV advert, I hope you'll really feel like it's moved you. And we know these campaigns work. We know that they are really helping lots of people to try quitting. And so just in the middle there, you'll probably all be familiar now with Sue Mountain. A huge thanks to her. Her TV advert's gone national. And then also there you've got Kathy Hunt from Durham. And then there's the lovely Tony Osborne from Middlesbrough. So it was a bit of I'm just basically on the putting, we need more people like this to come forward, share their stories. We know how important they are. And we've got a toolkit and all of this and briefing. So if you haven't seen that, if you don't know how to support this campaign, do just let us know. Next slide, please. So the next few months are going to be really hectic and exciting, and I wanted to just flag today for those of you who aren't involved in your local tobacco alliance, please do get involved with it. It's led by your local authority. Ending smoking is everyone's business. We've got 2 closed groups on K-Hub where you can really feel like you're becoming part of this big passionate community in terms of how we're all working together. So we've got a smoke-free NHS one, and we've also got a local tobacco control group. Did just want to flag to you all, please make sure you're linking to the really brilliant Fresh Quit website. This is what people who smoke are going to see on the TV, they're going to hear on the radio, and this is your website. It's our region's website. Help us keep this updated. It's the one-stop, you know, at that regional website to find out about how to quit, routes to quit, channels to quit, top tips, etc. For those of you who are really interested in terms of some of the advocacy we do, and particularly because of the tobacco and vapes bill that will be coming out imminently, follow us on X. Also on Facebook, we've got big, you know, loads of people chatting to us on there as well. And I did just want to also flag, you know, watch our videos on YouTube. I've mentioned the conference we had last September. All of those presentations were filmed. They're available to watch And particularly Robert West's is brilliant in terms of how we're going to really get smoking rates down. It's triggering quits at population level. It's as many smokers as possible every year making a quit attempt by any means and methods, etc. And that clearly rattled through all of that. So if you want to find out more, just email us at info@ and we'll triage it as a team. So they were my slides. And I just really now want to if we stop sharing those ones, Joe, that would be brilliant. And I just want to now introduce Sharon. I mean, it's just
sorry,
brilliant.
you're still sharing. I can move them, but I can't stop sharing your screen.
Sharing. There you go. Here we go. So yeah, this is our inaugural lunchtime webinar. Huge thanks for Sharon for joining us today. Sharon's the Principal Research Fellow in Behavioural Science and Health in the Tobacco and Alcohol Research Group at UCL. They are a phenomenal team. She's the Deputy Director of Behaviour Research UK. She's the President of the European chapter of the Society for Research on Nicotine and Tobacco, SRNT. And Sharon's research focuses on treatment for tobacco dependence within communities facing severe and multiple disadvantage, and how social determinants can influence uptake and use of mainstream smoke and cessation treatments and act as wider barriers to tobacco harm reduction. She presented at the conference last year. Honestly, watch it. You'll learn loads. And in May of this year, Sharon won the 2024 Impact Prize for the Society for the Study of Addiction. So absolutely huge thanks. She's basically awesome. We're delighted that we've got her as our first guest speaker. So I'm going to hand over to you, Sharon. Thank you.
Thanks so much. It's quite nerve-wracking speaking after you, Elsa, because you're such a phenomenal and passionate speaker. But I'll try my best. So yeah, I'm Sharon. I work at UCL, and for about 20 years now, I've been studying the psychology of addictive behaviour. Can I just check? Can you all see my screen? Can someone say yes?
Yes.
Great. Okay,
yes.
Brilliant. And I started my academic and clinical life working in the NHS. So that was actually an alcohol addiction centre. And then about 15 years ago, moved into studying tobacco addiction and nicotine dependence. So the aims of my talk today, I do a lot of work on inequalities, and I'll mention those bits of work here and there. But as I also said, last year at the conference, I spoke, that talk was completely about my inequalities work. But this talk today is going to be on another area of my interest, which is thinking about tobacco smoking as an addiction and how it came to be recognised as addictive. But how nicotine, although is a dependence-forming substance, is actually, when it's decoupled from tobacco, and more evidence is starting to support this, especially with the advent of e-cigarettes, that nicotine, when it's in non-combustible forms, is rather considered dependence forming rather than addictive, and why it's important that we understand these distinctions, especially when we're giving advice to people who are trying to quit smoking, because we know that when people are trying to quit smoking, one of the principal reasons that they often go back to smoking is that they say, I feel like I've just switched one addiction from smoking to another. And in the ASH surveys, we see that that's always one of the top 3 reasons why people, for example, give up using e-cigarettes, because they say, you know what, I feel like I'm using this more. I feel like I'm addicted to this. I may as well stick to the product that I really like using, because we have to acknowledge that a lot of smokers really like it. I really like using, and I know how it's going to kill me. And this thing, I just, I just don't want to swap one addiction for another. So it's imperative that when we're talking to people about nicotine in non-combustible forms, we're really careful with our language, and we don't maintain or perpetuate people's erroneous perceptions of nicotine and its role in cessation. So I'll go through that. So what do we mean by addiction? So Robert West and I have been thinking about this for quite a while now, and we've published several papers. This one on the right here is open access, and actually I haven't put any links into this talk because personally I find them quite distracting. But what I can do is put all of these papers together and send through to Fresh, and if they could share with the group. They're all open access. This paper here we published last year, led by Robert, but it's an editorial in Addiction Journal, and it's where we've come up with a glossary, if you like. It's an ontology, but that's a horrible word. It's a glossary of commonly used words in smoking cessation treatment, but with specific meanings and how they should be used. But not just, these haven't just been generated by myself and Robert and the team. These come from decades of evidence of how we know specifically what addiction is. It's quite a nebulous term, it's a throwaway term, but it matters. So addiction, we describe, and I won't go through the whole thing, but it's in the paper, it's a mental disposition. And the important parts of this, which make it different from dependence, it's repeated episodes of abnormally high levels of motivation to engage in a behaviour, acquired as a result of engaging in the behaviour before, but importantly, where the behaviour results in a risk or occurrence of serious net harm. My buttons aren't working. So these are the three things. And again, I can share my slides. Whereas when we're talking about substance dependence, slightly different. Now, you can have dependence when you have addiction, but you can have dependence without addiction. Okay, so what do we mean by dependence? Okay, so evidence suggests that dependence is realised as an impaired functioning. You feel a bit rubbish, basically, following the reduction or termination of the use of a psychoactive substance. So that could be nicotine, it could be caffeine, but it also can be other types of medicines or drugs. And you get this, basically, we're talking about a withdrawal symptom as a result of long-term physiological adaptation because of the use of that substance. So we all know that one of the common things when people stop using nicotine is that they feel a bit rubbish, they feel a bit lousy. Similarly, when people try to cut down their caffeine through tea and coffee. But that's different from addiction, and there's not that net behaviour, there's not that net population harm. And there's also not abnormally high levels of motivation. There might be levels of motivation, but they're not abnormally high. So why do people smoke? Why do people use tobacco? And the how, what, and why of people use tobacco tells us something about just how addictive tobacco is. Because why would people start smoking? Why do so many people fail to quit for the long term, despite knowing these harms? There's something about the relapse rate, which I'll come to, which leads us to know that that nicotine, when it's with tobacco, is uniquely addictive because the relapse rates are so high and so much higher than when people use nicotine without tobacco. Why do most report that they wish they'd never started smoking and try to make at least one quit attempt per year? So it's not just that people fail to quit, they are trying. And actually across the social grade, which is where my work sits, we see that people even, with really tough lives, they make as many quit attempts as people with more advantaged lives. But people fail, even when they use nicotine in other forms. So how do we know this means tobacco smoking is distinction? How do we know this means tobacco smoking addiction is distinct from nicotine dependence? And that's what I'll go through. And what evidence can we use to support this? Well, first of all, it's important to say that tobacco smoking now, or cigarette smoking, I'll use those terms interchangeably, was seen as a lifestyle choice. It was seen as glamorous. It's been marketed, as Elsa said in her slide, people took it up from very young ages. It was seen as cool. In fact, it's one of the reasons I'm a lifelong never smoker is because I couldn't inhale, not for want of trying. And when you're 13 and you can't inhale, you don't look cool. So I didn't take it up. And that's been, it's not seen as cool anymore. There's a social stigma around it. But, within some groups, it's still, and in different territories, smoking is still seen as quite, cool and glamorous. Before, and I'll come to the 1988 Surgeon General's report in a moment, but before that time, people knew smoking was harmful, but it was seen as a habit. It was seen as a choice, as a lifestyle choice. And of course, many of us are still frequent commentators on radios and news shows. I was on one the other week with somebody from a think tank who still want to suggest that it's people's right to smoke, that people should be free to smoke. But as Elsa said, it is an addiction of childhood. It is something that people start not intending to be lifelong smokers, of course, but they start when they're young and they're naive and they're impressionable. And by the time they want to quit, they've often been smoking for many, many years, and it's very, very difficult. So the turning point really, and this is in terms of nicotine being addictive, because I know people are probably thinking, well, what about the RCP report into tobacco smoking for cancers and other respiratory illness? Yes, we knew smoking was harmful, but it was seen as still a lifestyle choice, that if people wanted to smoke themselves into having COPD or cancer, then they could. It was the 1988 Surgeon General's report that brought together a body, a decade of evidence. It was just short of a decade, it's 9 years. The one before was 1979. 9 years worth of evidence that just showed with total clarity that nicotine, when smoked with tobacco, is an addiction. There was common parallels between tobacco when smoked, cigarette smoking, and other types of addictions. And throughout the report, they likened it to the sort of behaviours and symptoms that we see commonly with cocaine addiction and heroin addiction, and also alcohol addiction, although alcohol is kind of, as you'd imagine, it's quite sparse throughout the report, because at that time, and still now, it's the nation's favourite drug. And this report really shifted perceptions from it being a lifestyle choice to a habit to a serious addiction. And these are the points that I'll go through. So one of the key points how this report was one of the key points of how the report was concluded is that they said it is no exaggeration to say that smoking is the prototypical substance abuse dependency. So how did they know? And I'm using a lot of mice here that I've generated from AI. And the reason I've done that is because it's fun to generate them on AI. But also, a lot of this work, first of all, came from animal studies and then human studies. So similar to other substance dependencies, and typically here they're comparing them, as I said, to cocaine and heroin. Well, the first thing was they noticed that people who smoked, especially daily smokers, developed a tolerance. And that when they lowered the amount they smoked, that was met with a withdrawal symptom. That smoking happens in a social and environmental context, similar to other drugs. There is stimuli in the environment, which means that people are much more likely to get cravings. And you see this in animal studies too, that when animals are exposed to an environment previously where they have self-administered nicotine, they will go to look for that nicotine again. And we see that all the time now. You know, we see that when people say, I'm all right not having a cigarette until I go into a pub. And that's because that's a learned behaviour. And similarly, we see this with other drugs, that people get cravings. They get, you can see this in body studies, that physiological studies, that people start to get excited when they're in a place where they've previously had a substance that they've, seen as a good experience. Importantly, it takes place several times per day. So that tells you something about a tolerance. People are needing to do it. They're needing to keep their nicotine blood levels up. And it's bound to other activities. Similar to the social and environmental context, people find it really difficult to get rid of those few cigarettes a day, such as the one when they're having their morning coffee or they're going out in the evening to walk their dog. Again, it's bound to another activity. That craving, it becomes so linked to that activity. Even actually when people use nicotine replacement therapies, they still find it really difficult. And we see that people have repeated attempts and difficulty quitting. And one of the most convincing pieces of evidence for this in this report was this is even for non-daily smokers. Even non-daily smokers find it difficult to completely quit smoking. So that tells you there's something going on there. There's something reinforcing, both mentally and physically. So one of the things that we see, that nicotine was the primary reinforcer driving this addiction and the physiological component of this addiction, that smokers maintain nicotine levels despite smoking fewer cigarettes. So studies have shown that when smokers either smoke lights, the so-called lights, which we know are not really light at all, or when they smoke very low nicotine cigarettes, or when they try to cut down their cigarettes, what smokers do is they compensate. We call this compensatory puffing. And what I mean is they drag harder, inhale deeper, and they have fewer breaks in between each puff. And what this means is they're able to maintain their nicotine levels in their blood. So that's a real motivated behavior. What they're trying to do is not go into a state of withdrawal. And animals self-administer nicotine undeterred by environmental factors. So even if they were given, well, we don't do this anymore, but these are studies from a long time ago, as I'm sure you can understand, even if they're given electric shocks, even if they're put in mazes with lots of barriers and blocks, even if there's loud sounds, they will still try to find that nicotine. So we see this in other drugs. You know, I've always argued about this with animal models. You see with other drugs, and even smokers, you know, people work hard to smoke. You know, it's for people on low incomes, for people who have got a cocaine or a heroin addiction. You don't have to look at animal models to see that people go to quite great lengths to get to get their next fix. You know, we see smokers will spend a lot of money on it. For some people, the price rises are a barrier, but for other, it's not. They'll get illicit or they'll go to roll their own. So we don't have to torture animals to see this. We can see this in people. But nonetheless, back in the mid-80s, this type of research collectively with the other parts was showing that actually this is a really motivated behavior. And this is what we mean by abnormally high levels of motivation. That even when you're being deterred, and you can see you're being harmed, people were motivated to, or animals were, and now people were motivated to smoke. So why does it have this physiological reinforcing effect? Again, it's really similar to other drugs. So nicotine mimics the acetylcholine, which activates neuronal receptors. That feels good. That feels great. And when people are in a state of withdrawal from tobacco, smoking a cigarette activates those receptors again, and it feels nice. Nicotine affects the brain's reward system, the dopamine release. Again, we see this commonly in other drugs. And this is really important for understanding its association with other behaviours. Like I said, walking the dog or having your morning coffee. If you have a pleasant experience and you activate a dopamine release at the time when you're having that coffee, you have something what's called stamping in a memory trace of those two behaviours together, and it becomes positively reinforcing. And this is why the next time someone's having that coffee or walking their dog and they don't have the cigarette in their other hand, it feels anxiety provoking for people because they've got this positive association. As I say, it stimulates dopamine release. I've said that, and it affects therefore your memories, your learning and craving, and it's cue driven. And you know, nicotine, people commonly, we started to see that there was some very distinct withdrawal symptoms. That if this was just a habit, then why collectively across groups where there's these common symptoms? Because if it's a habit, you wouldn't expect everybody to have the same symptoms. People felt grumpy when they stopped smoking. They have a dry mouth. They have sleeplessness. They craved nicotine from a cigarette. And as I say, people had a tolerance. And combustion means smoking tobacco is the best way to relieve all of these symptoms. And I'll come to that. And smokers know this. So that's Ben Affleck, the famous meme. So, as I said, nicotine absorption from smoked tobacco. It's this here is a cigarette here with the circle lines. I don't know if you can see my arrow, but if you can, the one here with the peak with the circle here on the line. Yeah, you can. So that's a cigarette, and all of these others. So you've got nicotine. You've got gum here. So this is nicotine plasma levels within blood. Okay. So, and then you've got inhalators and patches, etc. And you can see here, and this, you know, this study is quite old now, but it still holds up now, that, you know, smokers know that if they want to get this bolus, we call it, or this nicotine hit, that they can get that really quickly. And it takes a longer time for them to get it through other forms of nicotine replacement therapy. It doesn't mean it's not effective, it does, but, you know, it's not as rapid. And it's why we need to help people to be more accepting of this and to not fear using nicotine, because what people really need to challenge and compete with this peak is to be using at least 2 nicotine products, and they shouldn't be scared of using nicotine when it's not with tobacco, because that's going to be the best thing that they can do to reduce their cravings. And quitting is hard. So one of the things that the report showed is that most people fail. So 95% of quits, 95% of quit attempts fail in the first year. Okay. And even, as I've said, even non-daily smokers found it hard to quit and to stop completely. Relapse is common. Similar to other drugs, heroin and alcohol, the longer cessation lasts, the greater the chance of staying quit. But in the report, it also noted that the context, similar to other drugs, the context was important. People had to be in an environment that supported them to quit and stay quit. And so it wasn't just this biological basis of their addiction. It was a social and cultural context as well, which underlies whether somebody's going to be able to successfully stay quit. And this relapse curve here, this is actually untreated smokers, but it's not that much greater actually for treated smokers, shows that the number of days since quit, and basically we see that if you can get to a year, your chances of relapse are lower than your chances of remaining abstinent. But we have to help people to get to that year point. We help people, I know, in the short term, but actually getting people to that year point and supporting them, it's not something that our models, our treatment pathways and models actually accommodate. But that's the point, that we need to get people to be thinking, what can I do to get to that year? What can I do to get to that year? So nicotine solves a problem it creates. So this is why it's really important that we don't demonize nicotine when it is decoupled from tobacco. So I've shown you this one here again, but here there's all these other ones, the lozenge, the gums, and we can see that, some of the mouth sprays and the lozenge and the gums do have actually quite good peaks. They peak quite well within sort of 10 minutes here for the higher strength mouth spray. But the problem with nicotine replacement therapies is that they often lack behavioural satisfaction. So patches, they can offer a steady release, but they don't mimic that hand-to-mouth action. Inhalators do provide that hand-to-mouth action, but the nicotine delivery is quite weak. And then the fast-acting options such as nasal spray are not well tolerated. And that's important because people have to like what they're using. So there are options, but people need to play around with them. And Cochrane reviews have shown that 2 products are more effective than 1. But in the interest of time, I'll just, that's just a summary of what I've said, really. Slower with NRT, less reinforcing, and nicotine has reduced addiction liability when decoupled from combustible tobacco, and I'll talk about that. So nicotine replacement therapy is not addictive. We wouldn't call it addictive. We'd call it dependence forming, because it doesn't have that net population harm. And there's many reasons why. It doesn't run in families or across peer groups. So I've shown 2 very famous people here. You don't get the glamorization of patches and inhalators like you do with cigarettes. It doesn't cause excessive harm. It causes, some grouchiness and, some withdrawal symptoms, but they're not harsh. It does not cause excessive healthcare costs at a societal level. The costs of it are actually to treat tobacco, not to treat using the product itself. And it's probably been helped by a lack of cultural and social status, but it hasn't ever gained that because, you know, it's just not a product that people turn to if they're not already smoking. So what about e-cigarettes then? Okay, so e-cigarettes have tested our knowledge and forced us to consider how the core concepts of addiction and dependence are defined, and I'll talk about why. So a little bit about e-cigarettes. They're the most popular quit aid in recent quit attempts in England. This data comes from the Smoking Toolkit study that we run at University College London. And in this green line here, you can see that e-cigarettes are the most popular when people are trying to make a quit attempt. And then here we have over-the-counter nicotine replacement therapy. So, you know, e-cigarettes really took off from about 2012, and now they're by far the most popular quit method. They're twice as effective as nicotine replacement therapies when both are delivered alongside behavioural support, and that evidence is now seen as robust by the Cochrane Living Systematic Reviews. But dual use is common. So if e-cigarettes were, you know, the answer, if you like, and I'll talk about why on paper they should be the answer to solving tobacco, they're not. Dual use is common. So here we've got dual use with nicotine replacement therapy, which is the pink line, and then we've got dual use with e-cigarettes here. So people do dual use with nicotine replacement therapy, and what I mean by that is smoking alongside, but slightly more people dual use with an e-cigarette. So it's not a panacea. So does that mean e-cigarettes are addictive? Because if they were, you would expect them to be an easy replacement from cigarettes to e-cigarettes, and they're not. And this is interesting because, as I've said, how nicotine is delivered is really important. This here shows, and there's many other studies like this now, but again, I'll send this one out. It's open access in Addiction Journal, led by Peter Hayek and colleagues. This is Juul, the brand Juul, which is like a pod-based system. And this shows, we've got the cigarette. These again are nicotine blood levels. We've got the cigarette here in the solid line, and we've got the Juul in the dotted line. And actually, Juul can rival a cigarette for nicotine delivery. And yet it's not popular. And again, people dual use alongside it. So something else is going on. So something's missing, and this is something that Robert and I and colleagues have been thinking about, because e-cigarettes offer good nicotine delivery, hand-to-mouth action, which we know is important. We know is for reinforcing, as I've said, for, you know, if you like, building memory traces for positive reinforcement. They also give people fingertip control. So if you, as you know, as I showed, when people smoke a light or they cut down, they actually compensate. They take in as much nicotine because they have this fingertip control. You can do that with e-cigarettes. You can have fingertip control with e-cigarettes in a way that you can't actually with nicotine replacement therapies. And yet, you know, not everybody uses them. They don't stay using them. They should be good at helping to reduce cravings because of the speed at which some of the devices can deliver nicotine. And, you know, there is a social and environmental context in which people can vape. It can be seen as permissive in some environments. And people have choice and flavours, and they're available cheap, and they're advertised online. And, you know, there's glamorous people vaping, as Leonardo DiCaprio and Katy Perry show here. But something's missing. And Professor Michael Russell, who I'm sure some of you will know, but for those of you that don't, was a pioneer in understanding nicotine and tobacco. He's a psychiatrist that was at King's College London, or the Institute of Psychiatry. He published this back in 1981. So, you know, way before the first e-cigarette had come to market. And he said that for anything to really rival the combustible cigarette, it needs to be a long-term alternative. It needs to be palatable and acceptable and be actively promoted on the open market. And it needs endorsement from health authorities. Now, we have some endorsement, we don't have as much as we should. but it should also be safer, and that this product would actively put an end to tobacco smoking if it could exist. But we have that with an e-cigarette, and for some reason we're not quite there. We're getting there. We're getting to this smoke-free target, but we've got a lot of work to do, especially amongst people who are incredibly disadvantaged, like where my work sits, people experiencing homelessness. Smoking rates are around 85%. And that's a growing group because of austerity. So, we shouldn't see that as a small group of people. So what's going on? Well, nicotine is uniquely addictive when paired with tobacco and smoked. And we know this now because there's other constituents in tobacco that create an additive effect and act synergistically when nicotine is burnt. And that's not present in e-cigarettes. The smell and taste of a cigarette are potent reinforcers. So we know that when dopamine is activated, that is partly activated through the sensory experience of exhaled smoke. And we know, you see, when people smoke, they like to look at it. You can get that with vaping, but that burnt smell and taste is not replicated. It's not replicated with tobacco flavoured e-liquids either. So there's something there. And that whole sensory experience, the sensory experience of lighting a cigarette, of having a lighter. I'm sure some of you have heard people say they miss their lighter. So actually, what we need to help people to understand is the gadgetry of e-cigarettes shouldn't be feared. They can replace that paraphernalia with other things. But there's something else that's going on, and I want to raise this, is that the messaging behind vaping is leaving people really confused because, as I say, these products could be, on paper, a very, very good replacement. But for some reason, we're not doing as great a job in promoting them. And this is the ASH survey. This is a youth survey, but the same holds up in adults. We're doing a really bad job. That more and more people are seeing e-cigarettes as either equally as harmful or more harmful, and and some people don't know, and that's probably really undermining people's quit attempts. So they're using this product. It's not quite a replacement. It doesn't feel quite as good as when they have a cigarette, and people around them are telling them that it's still really addictive and harmful and undermining that quit attempt. So we've got a lot to do on nicotine addiction moving forward. And, this is propagated. Elsa and I can tell you we spend a lot of time when these stories come out. Suddenly everything else goes in the bin and we're on LBC and the like, trying to correct these misperceptions. But almost weekly at the moment, there's a scare story about vaping, and it is a real concern. The only thing I can liken it to is statins, when we had the statins madness. So net harm. Okay, so going back to our definitions of addiction, well, smoke tobacco, yes, there's no doubt about that. NRT, no. And e-cigarettes, unlikely, of course. Why I say unlikely is the only way that we might potentially have some net harm is if e-cigarettes lead people onto smoking. The evidence at the moment for that gateway doesn't suggest that that's happening. It actually suggests that we've got a displacement going on. But of course, we need to keep monitoring that. So concluding thoughts before Q&A, smoking is driven by biological, social and environmental factors. Nicotine plays a role in both addiction, dependence and cessation, but it's qualitatively different in each of those scenarios. So that's the important part. It's not quite as clear of whether nicotine is good or bad, and that's not how we should see it. It plays a different role depending on their behaviour. Evidence shows that we can be confident that when smoked with tobacco, nicotine is highly addictive and difficult to quit. How nicotine is administered can lead to dependence and or addiction. And net harms, as I've said, are certain for tobacco, but very low for non-combustible nicotine products. I just want to thank my collaborators and funders, and thank you very much. And I'm happy to answer any questions.
Brilliant. Wow. That was so thought-provoking, so enormously informative for me. I mean, I was scribbling away poor mice. I'm pleased we don't do that to mice. Well, I hope we don't. And I do think actually quite often, Sharon, when I'm looking at some of the really some of the scare stories on vaping, when you dig into some of that research, it's using mice, isn't it? So yeah.
Yeah, we do still torture mice. The only thing I would
Right.
say about mice studies, and less so in the UK now, but one of the things I would say about mice studies is that's where varenicline came from. So we
Okay.
shouldn't completely throw baby out the bathwater. But yeah, we do torture them less. But often we see, I mean, I was on LBC, it's always LBC, about 3 years ago, where some cells were doused in e-liquid and they all died. All the cells died. So it's often stories like that which are blown up. And, you know, I've spoken to journalists that will say, well, vaping's a really great story. It sells so much. It's such clickbait. Because there's confusion, people will always click on it. So
Yeah.
it's a shame.
Right. I mean, so there's some, the questions are now coming in thick and fast. I'm going to look to the first one that we had, Sharon. Can something be a dependence that goes on to be an addiction, or are they two separate things?
So I guess the person's talking about, is there a transition from a dependence to an addiction? No. So they actually both start around when something becomes addictive, it will become dependence forming very, very quickly.
Mm-hmm.
And it, as will the addiction. So the best evidence that we have from that is heroin, for example, that when people transition into daily heroin smokers, it actually takes them quite a long time to transition into injecting heroin users. No one really starts like that comes later. But when people can start using heroin again, it's not necessarily because of the withdrawal symptoms, it's because of the cravings. The withdrawals come later. And you know, people do develop tolerances for dependence, which are far more manageable than the tolerance and the cravings they get for addiction, which is what drives the abnormally high motivation. So I'm heavily dependent on tea, but I can manage my symptoms in a way that if you were addicted to smoking or you know, cocaine, that you wouldn't be able to manage.
That's a really helpful explanation. Thank you. I've got a specific question around the current evidence about risk of e-cigarettes as a quit aid in pregnancy, including potential future risk and uncertainty. Leslie, just to say, we have got lots on K-Hub and things about this specifically, but Sharon, what would you say if you had a midwife asking you if she should say to a lady that, yes, use an e-cig?
Yeah, so actually, this is a timely question because only about 2 months ago, Sir Peter Hayek, whose work I showed there, published a randomized control trial comparing e-cigarettes versus nicotine replacement therapies for pregnant women. And you should be reassured that you can offer an e-cigarette, and the birth outcomes and the health of the mother for those who vaped was comparable to those who use nicotine replacement therapies. So much safer in terms of smoking and comparable to nicotine replacement therapies.
Thank you. And I think nice guidance very much is in in support of this as
and
well.
the latest Royal College of Physicians report, I believe, has now got a section on pregnancy as well. And there's some nice infographics around actually that are quite reassuring for pregnant women that can be shared.
Okay, great. Thank you. I'll come to the thorny issue around young people using vapes when they've never smoked tobacco, and about striking the balance, about keeping the message clear as positive for smokers to quit option. But Sharon, your personal views in terms of other risk-taking behaviours that young people may be doing. How worried should we be if we have got some young people who are using nicotine in this form?
Yeah, okay. So I didn't put that in the slides because I knew we'd have Q&A and this would come up. And if you're going to put it in the slides, you really have to unpack it, and I wouldn't have been able to give it time. So thanks for the question. Okay, so e-cigarettes are displacing smoking. So we will even if we don't want to, we will have some young people that go straight onto vaping that have never smoked. So that's like, if you see a Venn diagram, that's some people. And then you've got the people that we're unclear about, if you like, in the middle. And then on the right hand side, we've got people that maybe would never have smoked that are vaping. Now, just because a behavior is prevalent doesn't make it addictive. And that's really important. Coffee, for example, is a really prevalent behavior, but you wouldn't necessarily, it becomes addictive probably in some cases in a small amount. We are seeing now that curve, and we track young people in the Smoking Toolkit study, which is a repeat cross-sectional survey in England, Scotland and Wales. And we've been tracking young people's use, particularly of disposables since disposables have been available. We're now seeing that curve drop off. So we have to be careful that, is this a phase or not? So we will get some young people who are using them. And actually, we shouldn't be saying to young people, well, you must have smoked first. That's a really bad public health message, I think. But of course, we need to be mindful of it. So how do the message, I mean, I don't work in public health messaging, so, that's not my field, but I would say that what we can do, and what we've been discussing, is there are ways, and this is, top down stuff really, that we can start to manage young people's access to these products and availability, and marketing persuasion of these products without making them unattractive, unaffordable and unavailable to adults. So I think that we are starting to see that drop off. We need to be careful what we say to young people, but hopefully in the tobacco and vapes bill, we can hope that there'll be some sensible recommendations that are reducing young people's likelihood of using them, but not adults. In the same way that we've done, this isn't new. We do this with cigarettes.
Yeah, that's really helpful. And just for colleagues on the call, we will be really looking at that bill very carefully. And as you say, we've got very clear policy around the price, the promotion, the packaging, but I know we've got mental health trust colleagues here on the call today, and how incredibly important, for example, flavours have been, and how brilliantly our big mental health trust's been getting 50 a day smokers off cigarettes, by using vapes. So there is a
Can
question.
I just mention something about that, actually, because I didn't put it in into my slides. And one of the things that I hear really commonly is, and I say this about mental health wards because I've been doing some work myself with different mental health trusts, is that they say people use their e-cigarette loads and they're really worried that they're using it too much. And going back to my slide about nicotine delivery, a lot of e-cigarettes don't deliver nicotine at the speed of a cigarette. So they do use it more, but it doesn't mean they're more addictive. So we've got to stop thinking that more use is more addiction. What they're doing is getting nicotine into their blood more slowly than if they smoked. So the way that I talk to people about it, and I've developed some infographics for this, that vaping is like grazing on snacks all day, whereas smoking is like having a few meals a day.
Yeah, that's so incredibly helpful, and that picks up on Adam, who's asked this question. Is there data on the nicotine hit level someone gets when vaping compared to smoking nicotine patches? Your slide, is there a slide we can share that also shows it's...
Yes, there is, and I couldn't find it. I was trying to find I can get that for you. Yeah.
Thank you.
If anyone's interested in doing any more work, like having a look, Jonathan Folds, Foulds. Jonathan Folds is the literal authority on nicotine delivery across different products.
He is, and he's fabulous on Twitter as well.
He's very good, yes.
A really important question is it's Nicole in South Tyneside. Interesting conversations locally around clinicians. They're asking patients to stop vapes pre-op the same way as they ask them to stop smoking.
So I mean, the reason we ask people to stop smoking pre-op is because it reduces blood oxygenation. The tobacco actively reduces blood oxygenation. There is no tobacco in e-cigarettes, so there is no reason why people should be asked to stop.
Thank you. Can I be cheeky, ask a question? Some of the services we understand are feeling a bit under pressure, the stop smoking services, to to like adapt and to think about becoming stop vaping services. Thoughts, is this going to confuse further the population, and do we need clarity on this?
Yeah, that's I don't know if that will ever be a public health goal, and if it is, it's not for now. I think at the moment we have to be really clear we're going for a tobacco free future, not necessarily a nicotine free future. That might come, but right now we've still got 300 people dying a day of tobacco. You've only got to look at the the yellow card scheme report to see the incidences of serious and adverse effects from nicotine replacement therapies and e-cigarettes are minor. So we need to be really careful in what we're asking people to do. We do not want people to continue smoking. We don't want people to go back to smoking. As I've said, the risk of relapse is really high with smokers. So what we do not want to do is to confuse that messaging. And one of the things that e-cigarettes can do, and people do this with with nicotine replacement therapies as well, is use them for as long as they need to use them. So I think if we start to go vape free, that's really confusing for people. Just that point again, people are really attached to their cigarettes. You give people reasons to go back, to stay on them, they'll stay.
Mm-hmm. Wow. That's just, I think that's such an incredibly important, just how you've summarised that for me. I'll give to Joanna, because I think is this your question, Joanna? We've got one question left, I think, and by all means, if people have more questions, stick them in the chat and we'll do our best to work with Sharon to get her thoughts and answering them. But Joanna, Insight research shows people still believe for cold turkey is the best way to quit. How can we overcome this? This is probably too big a question in 2 minutes.
In the toolkit. So I showed the aids. That e-cigarette, that's a good point. E-cigarette is the most popular aid, but the most popular method is still cold turkey, just cold turkey, as we call it. It's really not very successful. And I think it's because people have this belief. You see this across all health behaviours as well, that people go, I'm just stopping it all. I'm not going to do that. I'm just going to go completely free. I don't really understand the motivation behind it. Often, though, people do say, well, I'm just swapping one addiction for another. I don't know if people saw, but rather unhelpfully, a Guardian opinion was Victoria Corrigan Mitchell. I'm not sure if I got her name right. But anyway, she said, the problem is with e-cigarettes, you're swapping one addiction for another, and you're swapping an addiction to a dependence. And it's a dependence that, you can address later on, but right now we want to save your life. So that's my last thought.
Well, thank you so much. And I think all of us here on the call today, want to save lives. We do absolutely want to stop people dying from 16 cancers, heart disease, COPD, stroke, all of that side of it. So I mean, this has been hugely informative for me. Thank you so much, Sharon. This presentation, I spotted it because it's a chapter in a new book. This book that's coming out. Should people read it? How do they read it?
No, don't read the book. I mean, you can. I shouldn't say that. The book is The Psychology of Addictive Behaviour, I think it's called, and I'm chapter number 33. And it's the only smoking chapter in there. But what I have done is this whole chapter is available free on the Open Science Framework. So when I get together the reading list, people can go there and download it. And I've written it in a way which I hope is, so it's written for first year undergraduates, essentially. So a real gentle introduction. I've tried to make it as accessible as possible. So hopefully, and any feedback that people have on that, I can't change it now, but it might, if I get a second edition.
Well, thank you so much. I will stick to time because we said these would be 1 hour lunchtime seminars. I hope everybody really, appreciates the time you've given us. Thank you so much. Joanna and I will be coming out to you all in terms of topic for the next lunchtime seminar. We'll have one before Christmas. You can all bring a mince pie to eat online. But a huge thanks, Sharon, for giving us the time to share your huge amount of knowledge and wisdom. And I think particularly for us in the Northeast, We need to view things from a health inequalities lens, from deprivation, from our health inclusion groups. Who are the people that we really now need to be thinking about supporting to quit and everything like this? And I think that's going to be incredibly important when we see the new version of tobacco and vapes bill, and just really thinking this through. And I think an audience for me, I think we need you in front of Sharon to explain all of this. It's probably going to be our MPs and things, so that they do understand the difference between these two. But without further ado, a huge thanks to the team, and Joanna in particular, for helping me, get such a great turnout today. And thank you so much. Okay,
Great.
thank
Okay.
you.
Take care.
Bye.
Bye.
Thank you. Bye.